Let me thank Mr. Schweikert, the chair, and I thank all of our witnesses for staying and hanging out here for this extended hearing. My name is Gwen Moore. I'm from Milwaukee, Wisconsin, and I'm going to share with you that 64% of my constituency is enrolled in Medicare Advantage. Is much higher than the numbers that you've heard here today. People have talked about the national average being 51, 52%. And so that has caused me to wonder about the appeal of Medicare Advantage to communities and constituencies like mine and the demographics that are involved in it. I guess maybe I'll ask you, Ms. Maroney. I had a great colleague named Maloney, so forgive me, Maroney. You say that you only deal with prior authorizations being denied in about 2% of the cases. How then can your plan afford really to provide people with the level of services and care when you, in fact, get all of your care needs authorized how do you do that? I was curious.
Thank you for asking that question, and congratulations on the high percentage in your district. Our organization believes in a high-touch, proactive approach to care, and so we try to get in front of a prior auth in advance of that care. So high-touch through clinicians that are complementing the private network specifically, so that we make sure that people are getting access to their drugs, they're getting access to their specialists, they're getting access to their primary care, and we also have care navigators that navigate to make sure that the administrative burden is out of the way. If we're doing that, then we're eliminating the prior auth process without them asking for it. We're just setting it up for them in advance.
That's very good. I appreciate that. Let me ask you, Dr. Fiedler, we've heard a lot about how upcoding, coding intensity and favorable selection really hikes up the cost of Medicare Advantage. How can you upcode and at the same time choose someone who has less health problems and have that sort of jive?
So I think there are so you can take any given person, no matter what health conditions they have, and what the MA plans have gotten very good at is finding an additional diagnosis that wouldn't, even if they're fairly healthy, that wouldn't otherwise have gotten recorded, and make sure that gets written down. Why is there favorable selection? I think what's also happening is, frankly, in traditional Medicare, you have a broad network, fairly lightly managed plan. On the MA side, you have networks, often fairly narrow, and you have substantial utilization restrictions. And so if you're someone who needs a lot of health care and you're choosing between those two options, often the traditional Medicare option is going to look more appealing because you think it's going to be easier to get the care you need.
All right, thank you. I am concerned, and maybe Dr. Fiedler and maybe Ms. Maroney, you might want to explain to me that it seems to be that there are more people of color, brown people, Latinos, African Americans subscribed in Medicare Advantage, and we've heard here today, people don't necessarily get the services that they're purported to deliver through Medicare Advantage. So it makes me wonder if people aren't being taken advantage of when on the basis of this demographic. So when we start talking about transparency, one of the things that concerns me is I think that former President Biden tried to get a handle on this, and of course President Trump really stopped the practice of trying to determine. Do you all think that it would help us with regard to figuring out how to reform Medicare Advantage if we knew whether or not these demographics were a part of that mix, Dr. Fiedler?
So I think it's absolutely the case that better data on Medicare Advantage would allow us to have a better picture of how the program's working overall and how it's working for particular communities. I think there are, frankly, major gaps in the data that CMS is collecting, and then to some degree the data that CMS is releasing on the Medicare Advantage program that will allow us to have a much more complete and accurate picture.
And just very briefly, Medicare Advantage is, of course, pays much higher than Medicare, Medicaid, even private insurance. It's nearly double the individual market Medicare Advantage. How would the loss of $1 trillion in Medicaid, the Affordable Care Act not renewing the premiums for people, how will will MA be held harmless? And the half trillion dollars triggered in Medicare cuts.
Okay, Ms. Moore, and
okay, I'll just let you answer, Dr. Fiedler, and then I thank the chair for his indulgence.
So if the sequester were to go into effect, that would have significant consequences both on the traditional side, traditional Medicare side of the program, and on the Medicare Advantage program.
thank you, Ms. Moore.
I yield back. There's never enough time, but
No,
I appreciate you all. Thank you.
Representative Gwen Moore of Wisconsin used her time during the extended hearing to shine a light on the experience of her constituents with Medicare Advantage. She explained that 64% of the people in her Milwaukee district are enrolled in Medicare Advantage, a figure much higher than the national average of about 51 to 52%. That led her to question why the program holds such strong appeal for communities like hers and whether there are demographic factors behind that pattern. She directed one question to an insurance representative, asking how their plan could manage to approve almost all care requests while denying only about 2% of prior authorizations. The representative replied that their organization takes a proactive approach by coordinating with clinicians and care navigators in advance. This allows patients to access prescriptions, specialists, and primary care without being burdened by repeated authorization hurdles. Moore then turned to Matthew Fiedler, the Joseph A. Peckman Senior Fellow at the Economic Studies Center on Health Policy at the Brookings Institution. She pressed him on the issue of upcoding, pointing out that Medicare Advantage has been criticized for inflating diagnostic coding while at the same time benefiting from favorable selection of healthier patients. Fiedler explained that plans often find additional diagnoses that might not otherwise be recorded, which increases payments. At the same time, people with greater medical needs may prefer traditional Medicare because of its wider networks and fewer restrictions. Moore expressed concern that communities of color, including African Americans and Latinos, seem more likely to enroll in Medicare Advantage yet may not be receiving the full scope of promised services. She questioned whether these groups were being taken advantage of and suggested that greater transparency was needed. She also asked if collecting more detailed demographic data would help reveal whether health disparities exist within the program. Fiedler agreed, noting that there are major gaps in the data collected and released by the Centers for Medicare and Medicaid Services. He argued that better data would give policymakers a clearer picture of how Medicare Advantage is performing overall and how it serves specific populations. The conversation shifted to finances when Moore asked about the potential effects of losing Affordable Care Act premium supports and the possibility of sequestration cuts. She wondered whether Medicare Advantage would be shielded or harmed if Medicaid faced a $1 trillion reduction and Medicare itself saw $500 billion in cuts. Fiedler responded that such cuts would have serious consequences for both traditional Medicare and Medicare Advantage. Moore closed by emphasizing her concerns about equity, transparency, and sustainability in Medicare Advantage,